Hello and welcome. I'm Dr. James Macielak, and we're going to discuss neck surgery or cervical surgery today. Prior to doing that, just to let you know that to do this specialized surgery, I had completed a board-certified orthopedic residency and then additional training for a spinal fellowship in Los Angeles, California before coming to Meadville. We have been performing this surgery here at the Meadville Medical Center safely and successfully for the last 18 years. By way of introduction, so you can understand the surgery better, it's important to understand the anatomy of the area with which we're working or concerned. And I'm going to utilize this anatomic model to assist us in that. This is a model of the neck with the muscles removed. Everything in white that you see is the spinal bones and the base of the skull. There are 7 neck bones or vertebrae. In between the neck bones are a soft tissue structure, the disc, which acts as a cushion for the spine. Indicated by the red structures are the arteries that travel in the neck to the base of the brain. And of course, in yellow are the nerves and spinal cord, which the spinal column or the bones protect in your neck. For illustration purposes, I'm going to use this smaller segment of a spine. This is actually a low back spine, but it's enlarged so it allows us to see things more easily. This is towards the front of the spine, and this is the vertebral body. This represents the disc, and the yellow structure represents the nerve. When someone has a ruptured or herniated disc that compresses or pinches on the nerve exiting the spine at that level, another way to develop that compression is if, with aging, the bone spurs develop at the area where the nerve is trying to leave the spine, and that can also create nerve symptoms. Now, the symptomatology from a pinched nerve in your neck may be related primarily to neck pain, can produce headache for patients, or the pain can travel or radiate into an arm or upper extremity. The analogy would be similar to striking your crazy bone at the elbow and feeling it in your fingers. If the nerve is compressed or pinched up in the neck, you can feel the pain down into your arm. Other associated symptoms are numbness and weakness, depending on the distribution of the nerve. Now, fortunately, the majority of people who are afflicted with this problem, a pinched nerve in the neck, are able to recover or get better on their own. And the initial treatment approaches are medication, physical therapy, or nerve blocks or injections. Unfortunately, a small number of people or patients do not respond to those treatments, and they are left with significant residual pain, and those are the ones who ultimately come to a surgical decision. In my mind, indications for considering surgical intervention are people or patients who have intractable pain or pain that we can't control, or they've lost the ability to function due to the pinched nerve in their neck. The decision for surgery ultimately is patient-driven, not doctor-driven. A pinched nerve on the neck is not a life-threatening condition. It is, however, a quality of life altering condition. It affects how you live your day-to-day life, and as such, any decision-making is done on a patient-by-patient basis. As I've told a number of patients in the past, there is no real right or wrong answer or decision. There's just whatever you, the patient, are most comfortable with in trying to decide how you'd like to take care of this medical condition, the pinched nerve in your neck. Now, if someone does have a pinched nerve in the neck, has not responded to conservative measures, then we consider surgery. And as you can see from the anatomic model, you can approach a pinched nerve in the neck either from the front or anteriorly, or from behind or posteriorly. 98 to 99% of our neck surgery here at the Meadville Medical Center is done anteriorly or through the front of the neck. That would necessitate an incision on the throat or the front part of the neck. The advantages for that are several. The first of which is that other than cutting the skin, you do not need, as a surgeon, to cut anything else. You simply spread the muscles apart, take the windpipe and food tube or esophagus to one side, the muscle mass to the other side, and that brings us directly onto the spine. The second advantage for the front approach is, as I demonstrated earlier on the model, the pathology or disc is in the front of the spine, and the way to most directly attack that would be from a front or anterior approach. If you approach the disc from behind, by necessity, you have to mobilize or move the nerve root and or spinal cord, which unfortunately can result in nerve injury. So for these reasons, we favor an anterior or front approach for our neck surgery. Now, the purpose of surgery is clear. That is to help you, the patient, with your pain, also reduce numbness or weakness if that's also an additional symptom. There are risks involved with surgery, just like with everything we do in life. One risk is certainly anesthesia, which is strong medicine that can affect your heart and your lungs. We are dependent on discussing with your primary care physician and whatever consultants they feel are necessary to make sure you're in the top or best medical care or shape you can be to go through a surgical procedure. Fortunately, with today's anesthetic techniques and monitoring, anesthesia risk is quite low, less than 1% of the cases, but you need to be aware that that may be a potential problem. We also have you meet in general with the anesthesiologist prior to the procedure so you can discuss with them any concerns you might have about the anesthesia, and that will give them the opportunity to fully explain to you what they will be doing from an anesthetic perspective from the procedure. It is critical to do this procedure under a general anesthetic. That's the only way we can get it accomplished, and so that's one of the potential risks with surgery. There is a risk of infection with this surgery, just like with any operation. Although we use antibiotics before and after surgery to help minimize that risk, the infection rate is 1% of the cases or less. If you should unfortunately develop an infection, treatment may require further antibiotic treatment or may require another operation to clean out that infection. Third risk or discussion point is the loss of blood. Fortunately for neck surgery, especially the front or anterior approach as we're discussing, blood loss is low to minimal. As a result, we do not have to have patients set aside blood for possible transfusion, and you do not need to be concerned about transfusion of blood products because we never lose enough blood to warrant that as a treatment intervention. Now, we are working on the spine, near the spinal cord and nerve roots. So statistically, there is unfortunately a risk of paralysis. Fortunately, though, that risk is very, very, very low, less than 1% of cases. And as I mentioned earlier, the risk to the spinal cord or nerves is lower from an anterior or front approach, which is the one we favor, versus a posterior approach. Now, as I mentioned, in the surgical approach, we do retract or move the esophagus or food tube to the side. The esophagus is the hollow muscle which carries the food from your throat and mouth down to your stomach. That can, because it's a soft tissue structure, develop a hole. And if that should occur, that requires surgical treatment in the form of a repair. So that is a risk with the anterior front approach, although it's statistically less than 1% of the cases. There is also a nerve that rests between the esophagus and windpipe or trachea that goes to your voice box or vocal cords. And that nerve is put on stretch to allow us to do our spine surgery safely. Occasionally that may result in a hoarse voice after surgery. Our experience with that is that's a self-limiting or short-term event. If symptoms persist, that may require evaluation by an ear, nose, and throat surgeon. As I mentioned, we do mobilize that food tube or esophagus. An actual hole or injury to the esophagus is rare. What is more common is a sense of fullness in your throat when you're swallowing after surgery. Again, our experience has been that that's a self-limiting condition and definitely improves for people over time. If for some reason it's not improving for you, then the appropriate evaluation would be undertaken to figure out why that is not improving or getting better. Now, the proposed procedure, as I mentioned on the anatomic model, was to remove the disc, the offending disc, from your neck and clear out or remove any debris or bone spur that was compressing or pinching. When we do that, that creates a gap where the disc used to be, and we fill that gap with a piece of bone. Now there's two sources for that bone. One source is from yourself. The other source is from what we call the bone bank. We have at the Meadville Medical Center over the last 5 years almost exclusively gone to use of bone bank bone. We found that that functions or works identically to your own bone and spares you having or undergoing a second incision on your hip or pelvis area, and also spares you the potential problems that can go along with donating a piece of bone to yourself. We have not found any risk of disease transfer for using a bank bone. As the bone is put in position, this will then biologically fuse or become solid over a period of 6 to 12 months. That does result in some loss of motion in your neck. Fortunately, the majority of neck motion occurs right at the base of the skull, so if your surgery is levels away from that, the actual range of motion or loss of motion that you're going to experience will be quite small. And as I discussed with patients before surgery, it's a trade-off to take away a painful range of motion, which is almost universally experienced pre-surgically, for a painless range of motion, which may be somewhat restricted afterwards. Now, whenever we fuse a segment of the spine, that may put increased stresses at the remaining levels or discs. And we know from following patients along and watching their x-rays that may cause degeneration or wear and tear at adjacent disc levels. In a very small number of patients, that wear and tear may, at 5 or 10 years in the future, lead to causing its own set of symptoms. And if that's true, that would need to be addressed or treated at that point in time. So that is a long-term potential risk of the procedure. Fortunately, my own office experience with that has been minimal. We have not seen that convert into